start this up?
We can start it off.
Okay, well, welcome everybody. This is January 30th. It's 5:30 and this is the City County Commission meeting. The subject of the discussion is the Mobile Crisis Response Program. And I'll kick this off to Shannon Bigelow.
I'm gonna put hot potato.
Should I say, ask if is there any public discussion, any public comments before we start the meeting?
Not on the agenda.
Yeah.
We still ask.
Okay.
We're very nice.
Right.
Okay, so we'll move on to, yes, sir.
I guess I would have a comment, but I'd prefer to wait until the presentation on the task force is completed.
Okay. So Shannon,
I'm gonna hand it over to Joe.
Okay.
But to start off by thanking everybody to be here today, and also both commissions taking the time out and doing the special meeting and coming together. This is a project that some of us in the city and the county have been collectively working on for over 5 years. I think probably pushing closer to 10. So we're finally getting to this point to be able to present some ideas and findings to both commissions.
Shannon, can I just ask that as everyone's speaking, because some of us don't know everybody, so if you all would introduce yourselves before you talk so that all of the commissioners know who we're hearing from, that would be really helpful.
That is a great idea.
Thank you.
My name is Shannon Piccolo. I am the director of the Park City County Health Department.
I'm Curly Ahern. I am the county commissioner's assistant. I am just running the technology today.
And I'm Joe Sexton. I'm the crisis response coordinator for Park County, and I'll be reviewing some information with the commissions.
And I'm Grant Gager. I'm the Livingston City Manager. Josh Shabalowski, City Fire Chief. Brandon Bickler, Park County Sheriff.
Kristen, do you want to introduce yourself too? Oh, sure. Kristen Galbraith, Director of Grants for the county. Thank you. Okay.
I'll begin and we can go to slide 2. This is perfect. So the Crisis Coalition wants to thank you this evening for accepting our invitation to meet and learn about the Crisis Coalition and the work and some of the what we've achieved and what some of our goals will be going forward. As I mentioned, I am the Crisis Response Coordinator for Park County. I am employed by Livingston Healthcare. The grant, the award for the crisis diversion work comes from the Department of Health at the state level down through the county, through the Department of Health, and the Department of Health has a service agreement with Livingston Healthcare to staff the coalition. So our coalition is focused on developing, improving our community behavioral health crisis systems. And it comprises of 11 local organizations who you can see on the screen. And within those 11 organizations, we have 27 individual stakeholders that participate in our crisis coalition. So you can see it's multidisciplinary and multi-organizational. We have law enforcement, education, healthcare, not-for-profits, and other community organizations, plus our peer specialists. Our crisis coalition was established in 2021, and we have a very strong and productive collaboration between Montana Department of Health, the Montana Healthcare Foundation, and the Montana Public Health Institute, which focuses on supporting our local efforts through funding and technical assistance. Go to the next slide. I think you would all agree the overarching reason we're here today is because we are concerned about the mental health and substance use crisis that is occurring nationally, on the state level, and locally. And you're probably aware that on our local level, Park County has elevated rates of behavioral health concerns and crisis compared to other communities in Montana and across the state. We could spend an entire afternoon on sharing data with you, but due to time limitations, I just did want to point out one statistic currently Park County faces a higher rate of suicide when compared to the state and the national benchmarks. On the screen here, to the left is, the left column is Park County, and I think the right county is the national data. So really, when you look at these rates, what we see is that Park County's suicide rate is somewhat like 3 times the rate observed in the US, about 1.5 times higher than the statewide rate. Currently, this year we have a tabulation of fatalities in there. This is running through January through September. As you'll see, so this data comes from the Office of Vital Statistics, and certainly numbers are subject to change due to late data entry. But currently you can see from January to September, we've had 4 suicides in Park County. And I don't know, I know Josh, the fire chief, they keep their own data. I don't know if it's been up, if you have any current data for the months of October, November, and December.
I have some data updates. I just pulled a snapshot for December 1st through December 31st of 2023. And I will agree that a lot of these numbers would be most likely inaccurate because the data that they pull, the company that's doing it is great, but the data that they pull is very surface level. They only pull it based on what they get from coding and CAD systems and dispatch and how it ends up on the initial call. During December, we had 21 incidents involving 23 patients. All of those calls were suicidal, ideations, attempts, behavioral, intoxication with multiple methods, alcohol, pills with attempts, several suicide completions, motor vehicle accidents with alcohol and suicidal ideations, and a lot of behavioral stuff that come out with intentional overdoses. So out of that, 21 people or 21 calls with 21 patients, 1/3 of them were in the county, the 2/3 were in the city. It's not represented here in this diagram. So the snapshot is actually greater than, a lot greater than, and it's more of a crisis. The way I have to go into my system and look at all the data is look at each individual call and then decipher and pull out from that call and the text that's in there to decide exactly what happened and what occurred and what the result was. But the final coding doesn't even come out as that. So when I pull it up, for instance, one of the calls I looked at in order to get this data, it came out as a environmental poisoning, anything. And then you read the text and it's an intentional overdose.
And any questions or comments from folks in the room or?
The 21 calls are for December?
Just December alone with 23 patients.
So this data that we're seeing is just completed acts. And it sounds like what we're hearing from the chief is a combination of completed and attempt, right? So I'm
Correct.
assuming,
Yes.
so attempts are much higher than what and this chart doesn't even show attempts.
Right, no, it doesn't. It's just the number of suicides.
And the number of suicide completions, that's obviously not accurate. In December alone, we had four completions, and that's not reflected. You know, if you look at September alone, that's 0, 0, 0, 0. I know that number is going to be inaccurate. And then the number of poisonings, more than half of these could be considered poisonings.
And then it sounds like also motor vehicle fatalities might also actually not be represented on here when they would be counted by the chief as.
You're correct, yeah. I don't think a motor vehicle accident would be underneath the number of suicides.
Thank you.
And I didn't pull the data for motor vehicle accidents other than 2 of these calls were definitively related because I was there or Chief Pierce was there. And we can attest to that there was an intoxication event. So we haven't even crossed that boundary yet to look that up.
Thank you.
So these are just the goals and objectives of the meeting today. It's just really inform decision makers on the history of the mission and the work of the Park County Behavioral Health Crisis Response Coalition and present our work and our recommendations for moving forward. We want to give an overview of the progress of the coalition's work. We want to talk about some of our priorities moving forward in our new grant cycle, which will begin in July of 2024. We do have some return on investment data on mobile crisis response teams in general. And then really what we want to talk about is at the local level, would, local government, local organizations be willing to consider the allocation of local financial resources needed to sustain a mobile crisis response team? So that's kind of the ultimate question this evening to consider. Go to the next slide. So this is Crisis Now. Crisis Now is our beacon. The goal of Crisis Now is to develop a continuum of crisis care services that match people's clinical needs by providing immediate and targeted support. Components of the model are intended to prevent suicide, reduce the inappropriate use of emergency rooms, correctional settings, and provide the best support for individuals in crisis. Part of the components of the Crisis Now model would include a crisis call center, which all of Montana has now. It's 988. It's been in operation since October of 2022. And then we also want to develop a centrally deployed mobile crisis team, ideally with a mental health professional and a peer support specialist or a paraprofessional to respond in person to individuals in crisis. And then the last component would be a 23 hours receiving center or some short-term stabilization center for individuals that can't be stabilized either through the call center or through a mobile response system. So for someone who needs more time to go through a stabilization process. Currently, as I said, all of Montana has access to the call center, but what we don't have access to in Park County is the mobile crisis response system, nor do we have a crisis receiving and stabilization program. So as we go back to the Crisis Now, Crisis Now wants someone to call, someone to respond, and somewhere to go when someone is in a crisis. We're trying to divert unnecessary ER visits, jail stays, visits to the state hospital if we can at all. So we live in a county today where we don't have access, particularly to the mobile crisis response team. So individuals tend to rely on less effective interventions. And this can sometimes burden law enforcement by responding to calls that other teams that are trained can handle. And so if we go to the next slide, so this is Crisis Now across Montana. So this is what is actually currently occurring throughout the state. Currently, 8 counties in Montana are providing the mobile crisis response team. That's Gallatin, Missoula, Cascade, Flathead, Silver Bow, Lewis Clark, Lincoln County. So they have teams with a mental health professional. They operate every day of the year and they are responding to crisis calls in the community. Approximately 51% of the population in Montana has access to a mobile crisis response team. I think it's fair to say that these teams would not be operating today without some level of public funding, both from the local level and the state level. And we can go to the next slide. So this is actually just a timeline of our crisis coalition and some of the work we have accomplished. We started the coalition in 2017, and one of the great accomplishments was the treatment court, which Shannon can just touch on briefly.
Yeah, sure. So the county, working with Judge Gilbert and the state of Montana, applied for a EJA grant from the federal government to start our treatment court here in Park County. That need for the treatment court came about through SIMS mapping process, which is a sequence intercept mapping system, which is everybody that works in behavioral health, law enforcement, and crisis get together and look at the continuum of care of somebody who is in crisis, and where do they meet law enforcement and the judicial system as they are in crisis? Where do we have gaps, and then where can we divert people out of the traditional system? And one of the goals through that original mapping was the desire to create a treatment court. And I can't remember, I think it's 3 or 4 years now that we've had the treatment court up and running.
Thanks, Shannon. A couple of things I want to concentrate on here is it was in 2021 that the county received its first diversion grant from the state of Montana. And then in 2022, we received funding from the Montana Healthcare Foundation for a behavioral health peer specialist. So what the coalition did, and that was well before my time, is they came together and created a collaboration between the Sheriff's Department and L'Esprit. And we hired a peer specialist who is housed in the Sheriff's Department and receives supervision both from L'Esprit and Livingston Healthcare. And what that peer specialist does is when law enforcement responds on the scene and law enforcement determines that this person is safe in the community to themselves and don't pose harm to anyone in the community, then they will call the peer specialist to come on the scene, and the peer specialist will help stabilize that person in the community and then continue to provide coordination and also just support. So it has worked well. We have some data on it, but it's been a nice collaboration between the different organizations of the coalition. And then if we go to the next slide. And then the other piece I wanted to really concentrate on was in March of 2023, we have 2 local individuals who have been certified as crisis intervention training specialist. So that is Janella from L'Esprit, and it is Dan Lashinsky from the Livingston Police Department. What they have been doing is working with a statewide organization to bring a 40-hour training academy to Park County for all first responders. So your police officers, your sheriffs, and other emergency management individuals will partake in an academy that provides them with de-escalation skills, trauma-informed care, so that if they are responding to a crisis call without a mental health professional, they too will be able to help stabilize. So that's something that was also funded through the grant, the diversion grant. Now, moving forward, historically, the diversion grant from the state provided funding for the operations of mobile crisis response teams. In the coming months, they are shifting that. They are going to a Medicaid model. So teams will now be rely upon Medicaid reimbursement for funding the operations of a mobile crisis team. So this past fall, we had conversations with the fire department, and the fire department in the city of Livingston are very interested in housing and managing and being the mobile crisis response team provider in Park County. What we realize though is when we look at volume of calls and the Medicaid rates, that will not cover the cost of operations. So that is really the point of coming to the commissioners tonight and just addressing the issue that in order for us to move forward and build out a mobile crisis response team that meets the new state criteria, which would have a mental health professional as part of the response team, operating every day of the year and be able to respond throughout Park County and also be able to respond without the assistance of law enforcement if necessary. And that's kind of where we are. So we are kind of shifting into that model.
Now, isn't it true, Joan, I don't know, you can cut me off if you're gonna address this a little bit later, that there are still some potential state funds through House Bill 878, which is pool about $300 million, that the committee has decided that the mobile crisis response teams that are up and running, that they will utilize some of that funding to assist them financially. And we have requested the state to, originally they really didn't consider Park County's process the mobile crisis response team as sort of being up and running and available to receive these funds. And so we've asked for reconsideration of that, which we haven't heard.
No, we haven't heard yet. What we need to do is demonstrate serious intent that the county is moving forward with what we call the Medicaid Mobile Crisis Response Team. That we are planning and have the funds available to now to start the Mobile Crisis Response Team this summer. So, and we do have some information on that funding. So the state was going to take our request to the work group. So we can go to the next slide. So I'm just going to give you some, looking at time, I'm going to give you some just really quick updates. So again, our coalition progress, we look at someone to call. We have a regional crisis call center. And currently, the Help Center is our local 988 crisis line provider. They give real-time access to a live person every moment of every day for anyone in crisis, having suicidal thoughts and emotional distress or concerned about someone. In 2003, they answered a total of about 512 calls from Park County. Approximately 35% of those calls were related to a mental health or substance use concern. Generally, 988 can stabilize and de-escalate nearly 80% of those who call them, using the caller's own strengths, support systems, and the robust 211 and mental health database, and the Help Center's crisis follow-up service. So their work, again, reduces the demand on other community services. And for the other 20% of callers, they're referred to community and medical services. A very small percent actually have the need to be referred to, or to have to call 911. And if we look at the next slide, just to give you a sense, so this is our crisis call, this is our 988 call volume, just from May through December. And the light blue is just the numbers of crisis calls. And then the next slide will just show you this, I believe, so this is someone to call. This is our 988 disposition data from October to December. And here is what we see. 83% of mental health crisis calls were resolved immediately over the phone. 3.3 of the callers went to the emergency room. They were probably referred to the emergency room by 988 because they will do that. And then 4% resulted in a call to 911 and required law enforcement. And then 9% had unknown disposition. So again, this is our first line of defense, and we work continuously to promote 988, both at our locally at Livingston Healthcare, but also through Live Well 49, which just recently wrapped up a pretty wide campaign on the use of 988. And our next slide. This is something to respond, and we kind of covered this. This is, we've used our crisis system funding for training, local training, along with the crisis intervention training and some first aid training as well. And then we talked a little bit about our current services, using the peer specialist to respond with law enforcement when appropriate. We can go to the next slide. This is just some of the work our peer specialist has done, and this is from May to October 31st. I'm going to go through this really quick. And remember, our peer support specialist only works 20 hours a week, but as you can see during that time frame, that 6-month time frame, that peer support network specialist did respond to 18 calls for 15 unique individuals. Now, I'm not going to go into the formulas here, but I do want to point out that when you look at natural patterns of diversion for mobile crisis response teams, they estimate about 15% of encounters result in a transfer to the emergency department. Whereas when you look just at law enforcement responding to a crisis situation, you're looking at about 26% of those encounters result in a transfer to the ED. So there is data out there to suggest that mobile crisis teams, because they can stabilize on the scene, trained adequately, can cut down on unnecessary ED visits. We can go to the next screen. And this is just this is somewhere to go. So this would be our crisis receiving and stabilization facilities. All I'll say about that now, it is the recommendation of the state that we consider moving towards a regional crisis system. So we are working with the 4 counties in Southwest Montana: Gallatin, Sweetgrass, Madison, Jefferson. And we are planning to apply for funding to do a needs assessment in the first year. And then as the year 2 and year 3 of the grant cycle, we'd actually be looking at trying to identify a location and building a crisis center. We recognize that the counties here are so small that in terms of volume, it needs to be done at the regional level. Next slide. Yeah, one more, I'm sorry. And so again, this is some of the potential impact of crisis services. So based on EMS and current peer support data, it's projected that a fully operational mobile team would respond to 17 to 30 crisis calls per month. This is what Josh referred to earlier. 17 is the number we get from our evaluator. They're looking strictly at EMS data. We still don't have 911 data at our fingertips. So you're looking at anywhere from 204 to 360 responses every year that a mobile crisis response team would respond to. Go to the next slide. And again, when we look at a mobile crisis team, research estimates that when a mobile crisis is included in response, we're looking at 3% of encounters results in a jail stay. When law enforcement goes out individually without any mobile crisis team, the response alone is 22% of encounters result in a jail stay. So what you're looking at is when you look at these monthly or yearly totals, we would, with a mobile crisis team, it is estimated that we would see 34 to 68 jail diversions. Next slide. So this would be the diversions for ED, emergency department diversions. And again, based on, I'm sorry, slide number 20. It's okay. There you go. It estimates that when a mobile response team responds, 15% of encounters result in a transfer to the ED, where law enforcement, again, it's the 26%. So there are some savings there too if we were using a mobile crisis response team. And you know, I do want to point out the savings. Now, when I think of an institution like Livingston Healthcare, we don't save money by when people don't come to the ER, and we don't lose money when people come to the ER. We can bill for ER visits. But what we look at is our ER capacity and also staff. Is our staff trained to handle these patients? And it's about, diversion is about providing people with the right care at the right time. And we know that in certain individuals who have a crisis in the community, they oftentimes end up either in the criminal justice system or in an emergency room that could actually be diverted in the community with some follow-up and some care coordination. So we can go to the next slide. I know I'm running through these quickly. This is just our involuntary commits. This shows there were 18 involuntary commitments from January to September of 2023. And I do know involuntary commitments are quite costly to local government. I don't have the figures, but. And then the next slide. So as we think about funding in the future, right now we have asked the Department of Health at the state level if we could use some of our unspent money for this grant cycle. So what we'd like to propose is approximately $90,000 that we would hand over to the city of Livingston to help with startup around equipment. That's vehicle, laptops, and other necessary equipment. You can go to the next slide. And while we recognize dollars are actually vital, we also realize that technical assistance is also important. So in our upcoming funding request, we plan to include 0.5 of technical assistance, a provider that has experience with and will support the program planning and training for mobile crisis response teams. In the areas of consultation would include care coordination, how to grow your program early so that first responders and others become aware of how to utilize the mobile teams, particularly important for rural areas, dispatching procedures, safety on the scene, response protocols, community support, and program development. And Shannon alluded to this earlier. Actually, the governor just approved it earlier this week. There are 2 pots of funding through the commission work. One pot is for mobile crisis response. The other pot is for crisis stabilization. The plan was for supplemental funding to continue for the operations. They really wanted to devote that funding to mobile crisis teams that were currently up and running and meeting the criteria of having a mental health professional on the team and responding every day. So we've had conversations with the state, and again, basically what we've told the state is that it's been our intent in terms of our planning to begin to be able to meet the Medicaid requirements this summer. So we're waiting on word back from the state. So that is, I will be frank here, if we can find some local funding to help support the operations, that would certainly be a stellar demonstration that the county is serious about moving forward and supporting the local crisis response team. And we can go to the next slide. Now, and I'm sorry, I hope you can, this is small. This is a very rudimentary budget of labor costs for the mobile crisis response team. And what I'd like to do is just run through it very quickly. I developed this budget. So basically, in order to meet the new Medicaid requirements for a mobile crisis team, you need a mobile crisis team that operates 24 hours a day, and you need a mental health professional as part of that team. It's an LCSW or a psychologist or an advanced practice nurse or a PA. So there is the 24/7 model, and the model can either be the team approach or it can be the individual approach. If it's the individual approach, it would have to be the mental health professional responding to calls. So in this budget, we have budgeted for a full-time program manager and lead. That would be someone who supervises the program and makes sure that it meets the policies and does in trainings. And then we've also asked for the mental health professional. And our plans is to have an on-call model. So we wouldn't be spending salary to provide to someone who's, could have downtime in between calls. We've also budgeted for the behavioral health specialist to be part of the team that responds. And then there is a care coordination component. Everyone who's a client of the mobile crisis response team is required to receive care coordination. And that's an important aspect of helping that person navigate them to the necessary services they need, helping them to get into recovery and maintain recovery. So the 3 models are up here. It includes the team model. It includes the 24/7 with the individual responder. And then it includes, I just used a 10-hour, 7 days a week. Again, the requirement is there is no requirement of a certain number of hours every day. So they just say you need to operate every day. The gold standard is 24/7. Lincoln County, very small county, only 20,000 people, rural, very rural, actually operates 24/7 with the on-call model of an LCSW. Now, your program manager and team lead could also be an LCSW, and they could actually do the program, they could do the training, and they could also respond to calls during the 8-hour workday. The other thing about the LCSW, the mental health professional, it doesn't, so if you have a peer specialist, they can respond remotely. The peer specialist or the individual can go out and then hook them in remotely, and they can do the assessment. Or you can also use an alternative. You could contract with a remote service. So if you look at, I don't know if I can read it. At the bottom of the page, I show basically, these are the labor costs. I've also included the Medicaid rates. This is based on 17 calls a month, and each call lasting at least 1 hour. So there's, at the bottom of the page, there are the rates. So we're looking at total mobile crisis response revenue, and then we're looking at the variance. So if we look at model 1, the 24/7 mobile crisis team model, that would be mental health professional and the peer specialist, 24/7, you're looking at about $157,000 a year that we would need to come up with funding. Now, the peer specialist there, we are going to carry funds over from the current grant that would probably run through January of 2020. So you could probably remove $15,000 off of that. If you look at the 24/7 model, and this would just be the LCSW or the mental health professional responding, it does dip a bit, decrease a bit because you've removed the peer support specialist, and that's at 114. If you go down to the 10-hour model, you'll see that your savings also continue to decrease. So that is the cost in a nutshell. Again, we don't know, this could be offset by the supplemental funding potentially coming from the state if we can show intent of moving forward with instituting the Medicaid mobile crisis response team. So I would like to open it for questions or comments.
I just wanted to comment, Joe sent me this PowerPoint late yesterday, so I did go and attach it to the county's agenda for today. So if anybody wanted to be able to go back and look at that, it is on our website.
These numbers at the bottom, that would be the maximum total without any additional funding, right?
Yes.
The Medicaid, the Montana 95,000 is allocated by the state, is that, am I reading it right? Total MCRT revenue?
Oh, yes, well, that would be coming from revenue that we charge Medicaid.
Right, okay, that's in the Medicaid.
Yes, that's the
No portion
Medicaid
of it.
reimbursement for a response.
Okay.
Based on 204 a year, but as Josh pointed out, it's probably likely about more like 30 calls or 304. Right. So actually these numbers, this variance would decrease. And again, just a reminder, these are just labor costs.
Right.
Again, we're bringing in though the potential of $90,000 to help with initial startup funds for equipment in a vehicle as well.
And additionally on that, like through this process, we have high hopes of looking at other potential funding sources with regards to other potential partners in the community, other available grant monies, other sources of income such as like OPID settlement funds, but none of that is also reflected
Right.
in those numbers.
Yeah.
These would just be a
Well,
straight.
these are the kind of numbers I like to see, but I want to know the max.
Yeah,
So now,
I think it is safe.
so it doesn't look that expensive either, I don't think, for what we're getting and achieving, what we need to do in this county for mental health. I mean, that's a pretty potent number, to help with the situation that we have, which is dire, right?
And I don't know, put Sheriff Bickler and Chief on point here, but, you know, I would like to also hear sort of kind of the law enforcement side of things with regards to, you know, what a mobile crisis team could do, you know, for law enforcement and responding to these type of calls.
Yeah, absolutely. As it's mentioned, mental health is a huge issue. And we're finally coming to some head with this at the state level. And I've been fortunate enough to sit on the Access Subcommittee Board for the state for House Bill 872. And Montana as a state has recognized that mental health is it's not something we can just continue to push in a corner and say that's just somebody else's problem. We have to deal with this and make it a priority. And fortunately that's come to a head. In law enforcement, we see it frequently, as does the chief, on a daily basis. And we try to set up all of these policies that we can have diversion policies in the jail because, quite frankly, the jail is not where they need to be. You know, that's not helpful. They deteriorate in the jail. Getting them the resources that they need is paramount. Mobile crisis is a huge help for us, just simply because there are so many folks that the involuntary commits are folks that we obviously we can't get them stabilized. We have to get them to the state hospital to get them that help. But that's a relatively low number with the folks that we deal with on the daily. With the mobile crisis, there's so many of those, and you saw it even just with the 988 numbers, so many of them can be stabilized in their homes with some continued follow-up care. And that's where mobile crisis comes in to play huge, is because they make those initial contacts, and then 2 days later, when maybe they're starting to feel that again, they're calling back and checking in on them again and helping to prop them up a little bit. It helps to build that relationship. We've lost resources that we had here one time, and Shannon and I have been at this a while, but when we used to have resources in Bozeman, we had a lot of folks that were here and that would call on the sheriff's office to come and help them because they knew that we could get them over to the Hope House. And we were happy to do that. If that was where we could get you over there and get you somebody to get you some help, we would do that for you without any questions asked. Then as those resources began to deteriorate and go away, what was once a good working relationship with someone who might be in crisis with the sheriff's office started to turn to a bad relationship. Because what happened is they realized that they didn't understand the fact those resources had gone away, and then we couldn't help them. And then it became, I'm not calling for help. And then unfortunately we start responding to suicidal ideations or heavy threat completions because the running agenda or the word was, there is no resource. We have no help for you. And that's an awful thing to have to convey to someone who's in crisis. Something as small as mobile crisis, being able to go out and just give them some resource to help prop them up a little bit. We obviously, I took a trip to Pendleton County in Rapid City and look at a model that they have there for a mobile crisis, a stabilization unit called Pivot Point. And Pivot Point, they basically serve 11 counties in that part of South Dakota. And it's phenomenal what they're doing there. I mean, if I could have picked 5 of them up and scattered them out through Montana on the way back, I would have. They're incredible. It's exactly what we need here. But we don't have that right now. I think mobile crisis is something that we can effectively put in place sooner than later and start to give ourselves some resources. Obviously, funding is always the issue. I mean, we always talk about it and everybody's like, that's a great idea. Who's going to pay for it? At some point, we do have to kind of step forward and say, this is a priority. We're going to spend some money on this, and we're going to do something good for our community because we're obligated to our community to try to help them with these issues that we have. We see it daily. And I think what's happened with mental health is when it's not affecting you personally or someone in your family personally, it seems like it's not as big a deal. But when you see it on the daily, how it affects families and what it does to people, I think it's very important. Mobile crisis is a huge help for us. I support those teams throughout the state. I think Missoula County is doing a model very similar or identical to what we're looking at here. I've met with them in meetings across the state in regards to the Access Subcommittee for Mental Health in the state. They have nothing but good things to say about that model and how that is working. I know it's always hard to get something started, but I think there's models out there. I think this is a positive model. And I don't want to speak for Chief Hart, but I would venture to say he would probably agree with a lot of that.
You want to, Chief Hart, you want to just come up and have a seat here?
Oh, sure. I didn't realize that was supposed to be for me. So I do agree with a lot of what Sheriff Bickler says. I don't say everything because there are some things that are like going to South Dakota. Right, I don't speak for that. I think that in the progression of my career in 17 years as a law enforcement officer in Livingston, it's just been a continual degradation of mental health services in Livingston. And you alluded to that. When I first became an officer, I think that our instances of dealing with people who are affected with whatever issues you want to bring up, we didn't deal with it that much. They had some resources, they had some services that they were able to access. Western Mental Health closed in Livingston some years ago. They took all of their resources over the hill. We still had the Hope House. It was a really good resource that we could get people hooked up with. They've closed that. And as much as everybody in this room will agree that law enforcement is not the people that we want dealing with people that are experiencing a mental health crisis. We're the people that get called. We've been the Band-Aid for a really long time. It's put stress on Sheriff Bickler's staff. It's put stress on my staff. It's put stress on Chief Chadalowski's, did I say that right? Staff. And now we're having this conversation, we've been having it for a long time, and any progress, I believe, is positive. And if we can make this happen, I think you're going to see a real positive for the community in terms of people that need to access that resource. You're going to see an improvement in services that the Park County Sheriff's Office, the Livingston Police Department can provide to the community. He's short-staffed, I'm short-staffed, I think you're short-staffed, and we're struggling to cover calls that are meant for us, on top of trying to help out somebody that we don't have the tools to help out. I know that Jeanette has been a godsend in a lot of ways. I think you would agree. And she's definitely been instrumental in helping us not have to deal with a lot of those issues and helping a lot of people out. So any funding that we can provide, I encourage the both county and city commission to strongly consider it and try to make this work.
Thank you, sir.
I was just gonna say, I mean,
I will speak to it.
I was just gonna also prompt you maybe a little bit, just because we've sort of done a little bit of a high level view of the idea of housing in your department and just maybe what that would look like and, your conversations with Missoula that has sort of that similar.
Yeah, we've had quite a bit of interaction with Missoula County, with the fire department out there. They've been housing it for a while now, for several years, I believe 3 years now. And they're up to, Jeanette, was it 5 personnel now?
Yeah,
Okay, and they're responding to over 800 calls a year. Currently, it's
quite a
housing in the
bit.
fire
It's
department.
an all day on the run.
Yeah, they just go from call to call, basically, correct? Raging success. They've had so many accounts, personal accounts, where the captain that runs the unit has come to me and said, we've had X number of incidents that have resulted in positive outcomes, whereas in the past, all of those types of incidents would have resulted in something really negative. They're pleased with it. The community is pleased with it. They are garnering more and more support daily. And many areas of the community have reached out to them on the regular with support and finance and funding and everything else that they can offer and donations just to make it happen. It's a very positive model. I foresee us being able to duplicate that model here, maybe not to the quantity that they have, with the personnel and one of these models that we've described thus far, either a 10/7 or a 24-hour model. I would hope for the 24-hour model. I think it would be beneficial to have people on call. I do have resources to tap into for personnel that we could probably look into getting on board. I don't think that would be a far stretch at all. We just need overall support, overarching support from both the city and the county and the community members to make this happen. Just to kind of echo what you were talking, both of you guys were talking about, the resources aren't there. Traditionally, 911's been called to solve every problem. You have a fire, you have a shooting, you have a water leak, you have a person in the river, whatever it may be. Any incident, anywhere, anytime, 911's the catch-all. And we finally reached a breaking point where we're answering so many calls at the same time that we don't have all the resources to put towards them. And now we're dealing with a situation where we don't have the tools to make it happen. This would afford us the ability to have the personnel and the tools to make it happen, to chisel out another portion of that call volume and add another level of service to this community. I was recently up in Alaska, personal story, up in Alaska on I was doing a fishing charter with my kids, and the guide was telling me how he really wanted to move to Montana, and he has 2 young children that are preteen, teenage, 12 and 14 years old. And they were really excited about it, and they traveled out here. And the deterrence, why they shut down the entire idea, they had jobs lined up, they had everything set, they were going to move here, they were really excited, and they shut it down because of the suicide rate and the mental health and depression. So they didn't come here. And that really struck me. I was like, oh my gosh, are you kidding me? That's really why you chose not to come here? He said, absolutely. So it just kind of, it spreads all across every level of the community. And if we don't jump on it now, pretty soon we're going to be overrun with it. It's going to be a major, major problem.
Joe, I see Bruce in the audience. Hi, Bruce. Is LHC, hate to put you on the spot, has an interest as a kind of third party, as the third leg of this stool for the crisis?
It does impact us too, from the standpoint that, if somebody comes into the emergency room, these are trauma certified physicians, they're not mental health professionals, so it's something that they're not used to dealing with. And if they're an involuntary commitment, they usually end up on our floor with one-on-one care, because especially if they're suicidal, we have to have somebody watch them and care for them. So it's not the best use of our resources. So, yeah, we would be interested in considering something.
Shannon, would, I guess I don't know, I'm gonna direct my question to you and you can send it where we're. Would our 911 dispatchers then be trained, if someone called 911 to perhaps dispatch this unit and not have to dispatch the fire department or the police department or even police or sheriff, so that call volume is getting pushed away from those other?
Ideally, in the circumstances where it's safe too. So, it's 911 is going to be trained, but they're also going to be trained up what the mobile crisis can do and can't do. And, making those safety calls with regards to, because they are they are non-law enforcement positions. And so there are going to be circumstances that it's inappropriate for them to initially respond to because of safety threat. And in those cases, law enforcement would make that call of, no, everything is clear, and they could bring in the mobile crisis team. If there's no safety threat to begin with, then there would be no need for law enforcement to respond to initially. So it'll probably work both ways. But the idea is, yes, dispatch would be able to dispatch the team when they're working.
And part of that would be the technical assistance. They would really come in and help us look at written agreements with law enforcement and first responders, and just outlining kind of mutual protocols, because that will be a piece that has to be worked out, or even agreements with 988. If 988 is on the phone and they have assessed the individual, but they may still think they need some community, involvement. So there's quite a bit there that has to be put into place.
And I also think, you can speak a little bit more, Chief, that I like the idea of this model of housing it in fire and rescue, because they do just normally work very closely and hand in hand with law enforcement with everything they do and respond on a lot of calls together. And so they understand the way that law enforcement operates and they understand the issues of safety and what's appropriate for them to go into and what's not appropriate to go in versus having the mobile crisis team housed somewhere else in sort of a non-related entity. You know, I think then it may take more time to kind of build that trust and that understanding and that communication with how that response works.
I would say that's accurate. Traditional boots on the ground employees and fire rescue law enforcement, any of those capacities, you recognize those threats when you get on scene. You can understand the call, the type of call, the situation that you're walking into. You can always hold and back out, call for resources. You know who to call, when to call, and how to call. Versus somebody from a social services aspect that maybe never really did any work in the field. And then they'll get out there and maybe get in above over their head. The hot water, that may be pretty dangerous. So the hope is that these individuals will be trained and may be very familiar with fire rescue and law enforcement, as Shannon said, and they'll be able to identify that and get in there and be as safe as possible. And it's a nice working arrangement and agreement already established.
The only executive we haven't heard from is our chief executive in the city of Livingston. It would be great if you were also invited to speak. If you have anything you think we should know, we haven't heard yet.
Yeah, I thank you, Vice Chair. I appreciate that. I guess I would just reiterate back to a point Joe made earlier. And really the point of bringing everyone together this evening is to evaluate those next steps, because I think at a staff level, we are at a point where we are ready to take the next step and move forward if it is the will of the commissions jointly. Thinking back 10 months ago to our budget planning session, I think I heard fairly strongly from all 5 commissioners that were in office at that time that moving forward in a capacity that had expanded the social work aspect of our enforcement was something that you were all interested in. I've heard that since from the newly seated commissioner on the city's side. So, it's my understanding that this is something that we're supportive of, but we're not the only operator if this is to move forward, and it is very much a community partnership between the hospital, the city, and the county. And so that really is the goal of this meeting today, is kind of to get an understanding from everyone involved that whether there is a willingness to proceed with a program like this, because we do a lot of work on a monthly basis with the existing community paramedic and peer support positions that we have, but this really would be taking that next step. And obviously it's coming up on budget season, and we're having a lot of different budget conversations as it is. And so this seemed like a good opportunity to really understand what the will to move forward with this is from all commissioners.
Thank you.
If I may ask, excuse me, if I may ask a question. I think Chief Chobowski, I think is that right? Alluded to it earlier. What do you think the breakdown is between city and county responses that would fall under this umbrella?
As far as
2/3,
numbers?
1/3, yeah, just percentages as you've seen for the last year.
Just from my snapshot in December, it appears that 1/3 of the calls were county, 2/3 from the city. I would have to look at a broad spectrum just to see exactly what that laid out as. And I would say that's probably pretty consistent.
And
Chair Tinsley, how would you like to handle this? Do we want to hear from each commissioner? I wonder, Mr. Gager, if it's helpful for you and the team as well.
Well, Grant and I have had several conversations. County's definitely hurting for money. We're, with everything involved, we're close to $1 million in the hole. General fund is about $500,000 in the hole. We're working on it. It's customary in my realm that the newest commissioners just open your wallet. And we really would appreciate that. It's been part of our process, working with Shannon and working with this for 3-4 years. heading towards this. We knew it was coming. And so it's definitely my goal to fund this. But quite honestly and very truly, there'll have to be layoffs in Park County. I don't see any other way around it. That's my take.
I would totally support this. Our treatment court program has about an 80% success rate, which is phenomenal. But it comes down to the budget for us, for sure.
Kind of 5 years for us new people was thrown at us quick, but, I come from fire and EMS, and I see the benefits of this. Less calls for the sheriff department to go after. I don't think a lot of people understand how this would work. This is like 4 days before an incident that would probably get called on, that they would not call 911, but they call the 988, they call the suicide, they call that, and they get into this, and even before we've had to go out on a late night call, this would already be handled. So to me, I think it's a very good deal. We do have to look at how we're gonna put it into our budget and how we're gonna do it. And then hopefully get grants, state to pay for it, other people.
Commissioner Welch?
So I've had friends commit suicide. I've had family members commit suicide. And we have a beast of a problem in our county. 3 times the national average, 1.5 times the state average. I have a hard time seeing how we can't do something along these lines, whether it's the gold standard or one of these other options. We have to choose something. And whether the money, which is really the crux of it, is made up with an agreement between the city and the county to cover shortfalls, I'd love to entertain conversations about that, but we have to do something. So my gut is to assist the process as far along as humanly possible to get us to a gold standard, to get us to a point where out-of-state sheriffs come and take a look at our facility and says, man, I really want to put one of these things over at my spot, Kansas or wherever. Yeah, that's how I feel about this.
Mr. Lyons?
You know, I appreciate the budget discussion, and I think that the level we're at here tonight is the policy discussion, whether or not we support furthering the strategic and budget discussion once we get there. And it seems like there's a pretty strong consensus that we feel from a policy level that we're there. And speaking of the budget, I just want to, we look at the reimbursement from Medicare, we look at, potentially bringing in other grants. It's, to a certain degree, it's diminishing the problem when we reduce it in numbers. And we're talking about saving lives potentially, and I think that's pretty important. So I think from a policy standpoint, strongly support it. And I think I trust our city manager when it comes down to working through the budget with us, that we can figure out a reasonable and sustainable way to do it from the city's budget.
Commissioner Schwartz?
I agree with everything that both of you guys said. We can't afford not to do this. We have to find a way to fund this. I know we're working on our budget now as well. I'd like to see this included in there. This is something we've been talking about for at least 7 years. I've been on the commission 8 years now, going on my 9th year. way back when, when we were doing the assessment early on. Things haven't gotten better. It's only gotten, the crisis has just grown. So yeah, I'm definitely on board with this, everything that our professionals have talked about. But it's imperative, I think, that we find funding for this. I yield.
Thank you. Vice Chair Newt. Thank you. First, I want to thank Chief Chabalowski, Chief Hard, Chief Pierce, and all the other first responders. I don't think this is what most people think about when they imagine your jobs. That said, I agree with all my fellow commissioners and Commissioner Schwartz mentioning that this is not a particularly large number when you think of our general fund, 8 or 9 million, I think it is.
Yeah.
I recognize that our general fund is quite a bit smaller than yours. And for us, I think this is totally affordable. I also agree with Commissioner Lyons that I believe Mr. Gager and his staff can figure it out on the city side. I'm also appreciative of the City of Livingston staff, when being called to rise to the occasion, is rising to the occasion by their willingness to find a way to house this within the city. Thank you. Falls in line with what I've been hearing on the commission for the last 5 years. I think we're all being asked to rise to the occasion, so now it's time to see if we're gonna meet the moment and do the hard thing to make it happen. Thank you.
Yeah. I agree with all of you. And I guess the last one, we've been talking about this in the city of Livingston prior to me being on the commission. I made comments to the commission about the need for a social worker before I was the commissioner. This is so needed. Commissioner Wells and I, a friend this week, family was affected by this. So we need to do something. And looking at the budget here, I think we can find this. We can make this work. And we need to make this work. And if we look at the dollars and cents of it and look at our chiefs sitting around the table here and what this will pull away from some of the calls that they would be handling, and they can go out and provide services in other ways that they need to be taken care of and not being tied up, for hours and hours on a call like this, where we could have someone who is trained to do it and you're not trying to just, I know you all do the very best that you can, but we're also putting you all in a position where you don't need to be either. We can provide someone who's trained to do this and take care of that so that you can go and do the other work that you're really meant to be doing. I think that we need to do this. So I guess I'm going to turn to Mr. Gager and say, help us figure this out, will you please? And let's figure it out. So.
Well, thank you, commissioners. I think that was really the goal that I had for the evening, was to kind of get a consensus that there's a willingness to move forward from our side. And I think I've heard that the county certainly has a willingness to move forward. So I look forward to working with Joe and Shannon and everyone else on the crisis response coalition to move this forward.
I'd like to say, Joe, thank you very much. It was a great presentation.
Oh, and
Yeah.
if there is more information or hard data that you need for, as you discern this, please let the coalition know.
Shannon, thank you as well.
Thank you.
So with that being said, is there any public comment? Yes, sir.
And name for the record.
My name is Andrew Mitchell, and I live at 113 South 9th. And without getting into the details, I have a long history in emergency services. And given the thread of the conversation, I'm a little reticent to ask my question, but I will. given that the root cause of suicide is alienation, how does this investment address that? It just kind of seems like we're buying a bigger Band-Aid and shifting the workload, which I get, it's definitely needed. But I don't see how this addresses the root cause. And that's all I wanted to put out here. Thank you.
Sure, I can address that a little bit. You know, I've been a commissioner going on 12 years now, and I've been in meetings in Gardner, Pico, I don't know how many times, Sage, different teams, different people looking at the issues. A lot of people who lost their loved ones, trying to start a coalition of working on these items. They all start out pretty well, but they always seem to fall in a couple years later. And in my mind, starting something like this might be the start that they need to come up with other things. That's what I see. I mean, I can't even tell you how many meetings, and as a city public works director, how many meetings I've been to where a large group of people, 50, 60, got together to want to do something. They always seem to fall short. And so I think if it's a city county basis to start this program, maybe we can help them do other things, in my opinion. Thank you. Shannon.
That's a very good point. When you're talking about, what we're talking about here, it's more of a secondary and tertiary prevention. We're dealing with individuals in the crisis at that time. But the county and the city, through the health department and other departments, are looking at what we could call primary prevention, the very root causes of what's going on, to help address those concerns. And so people don't end up rising up the pyramid and needing those services, those crisis services. That being said, as you work on those, it takes time to implement those type of preventive activities and to get people to where they are, that they are not going to need crisis services. That doesn't mean that we shouldn't be addressing the people that are in crisis now. And so that's what this is doing. We have implemented communities that care through the health department that is looking at school-age children up to the age of 18 and risk factors that our youth are facing, and what we can provide those youth with protective factors so that they are, when they become adults, better prepared for life and don't have those issues. So it's two sides of the same coin. This is something that addresses, yes, people that are in crisis now, but we are looking at things to do that preventative care, and so that we can provide those opportunities so people don't rise up there. But again, we have to address those people that are in crisis now and give them the best help they need at this time.
And Shannon,
Excuse me. And on top of that, I mean, I was a board member of Western Mental Health. We met in a few once a month and houses for crisis people all over the state. Livingston had a very large building that we treated. We had 9 counselors at one time working out of there. And as the state funding got cut, we just got cut more and more. We proved that we could treat a patient for $2,500, where that patient goes to Warren Springs $250,000. I thought we had a good show. We had a Hope House in Bozeman. And in this last 6 years, it kind of just all fell apart and the funding from the state stopped. So it's good to hear that there's funding coming back. And I'm not surprised Missoula, but Western Mental Health is located in Missoula. I'm not surprised that Missoula is doing a great job on it. They're very smart people. We just lost them.
I have just a comment. So I worked for Western Montana Mental Health here in Livingston. And when we closed, I never stopped working with those individuals. I kept working with them, if it was cleaning their house for them or just taking care of daily activities.
And I built this relationship with the people here in this town. And I do work on prevention every single day. So this support is needed.
Thank you.
If I may also, the model, guys, of without the peer support specialist, I would implore you not to consider that. I have personally witnessed Jeanette de-escalate crisis and change people's lives and the direction of the course that they were going on, the trajectory. I ardently believe interacting and doing a lot of outreach and working with people in these demographics and having been one of them myself, that she is a lot of people's lifelines. If you're considering this program, I wouldn't just see it as, do I get the luxury mob? This is like at its foundation, those relationships and her ability to, and especially if you look at the discrepancy between cost of the peer support specialist versus the LCSW or other mental health professional, their time can stretch longer, their follow-up, the care coordination. She does all of that right now. The hours that you have in your graph do not nearly adequately represent the amount of time that I've witnessed her put into that. And this one other thing to your comment, sir, there is some funding coming from the state to the Board of Health here for isolation and people who are isolated. Primarily the seniors center program, or the seniors are one demographic. The other is young adults. When they get out of high school, college, their isolation is skyrocketed. That funding doesn't cover those younger people. They've decided to just go with the state, but they're asking for people to volunteer, to get involved, to outreach, find people that are isolated and give them an opportunity to give feedback and to build a program. So that's something I'd follow up with the commissioners or with that. We can all do that, help people who are disconnected from our community and help them get connected. There's going to be a survey that they're going to be promoting that we should all get kind of spreading the word out. Thank you.
Name for the record, please. Name for the record. What's your name?
Sorry, Brian Mine.
And, if I could just respond, and I'm in total agreement with your observations. Livingston Healthcare works very, very closely with Jeanette. Jeanette provides a lot of service for our patients. And, Jeanette also, I know, has met with our behavioral health providers, and we know that we have a subset of our patients who make their visits, have fewer no-shows. Therefore, they're getting the treatment and the counseling they need because of the peer support that Jeanette provides. So it's a critical element in crisis care. The other thing I want to point out to your point about crisis diversion, and the diversion grant does primarily concentrate on the diversion. How do you keep people out of the ER? How do you keep people out of the jail or the state hospital who don't really belong there and could be maintained in the community with certain supports? We are waiting for the next RFP to drop from the state. And in that RFP, the coalition has decided to fund probably a couple of different care coordination positions, because we know that care coordination is critical for this population, that once they go through a crisis, we will hand that individual over to one of our care coordinators or peer specialists so they receive the treatment, the counseling, and the follow-up they need to help decrease or alleviate this individual going into another crisis.
Well, kudos. Thank you.
Sure.
I think we could use more of it here.
Any other comments?
I believe Mr. Hannawalt online had a comment, and then I have one other person that's unmuted, so I'm just assuming they would like to make a comment. So Kent, if you want to go ahead, and then I'll take your call.
Yeah, Kent Hannawalt, Swingley Road. I also have an EMS background, also heartily support this idea. One of the things on your very first slide, Joe, is a reference to 23-hour stabilization. Is that available now? Is that something that's in the works? You work with LMH, so thank you.
Yeah, that's a good question. Unfortunately, that is not available in Southwest Montana. In fact, I think there's only 2 counties across the state that are working towards opening a receiving center. One of the things we're moving towards in our new grant proposal, which will go into effect in July, is working with our surrounding counties in determining where would the best area be for opening a crisis receiving center. They are, they're costly to run, but that is one of the components of the Crisis Now model, and we will be working towards that, doing the needs assessment in year 1, but hopefully in year 2 and 3, with state funding, we'll be, moving towards opening a receiving center. And I invite Sheriff Bickler to comment on that. He knows much more about that aspect of the model.
I would agree, and that's kind of the way that's moving towards. I know the state has adopted the fact that we certainly need regional centers, and not just, and again, like we said before, the state hospital has its own component, and it does have a need there. But the majority of the people we deal with, we need some regional resources. So I was happy to hear that they're moving in that direction. However, those are long-term plans.
Yes, they are.
Right? Those are big $30 and $40 million brick and mortar buildings that are going to take some significant time. So I think this is the beginning leg of starting those resources.
Unfortunately, and I don't want to speak for Gallatin County, but they actually were moving towards a receiving center through the Hope House and had plans and had budgeted for it. But with the pandemic and then the cost and in supplies and building, it just became cost prohibitive. So unfortunately, we have no receiving center. So basically our ERs, our receiving centers, Bozeman Health does have inpatient psychiatric services, but that is for people that are experiencing a really severe episode, need inpatient.
If I might just add to that just a little bit and kind of put it back on Sheriff Bickler, sorry. The state hospital, if I stand corrected on it, most of what they have there is full, and a portion of it is forensic based.
Correct, because Galen is not open at the moment.
Okay, so there's a waiting list basically to get in there. So we have nowhere to take them.
That's correct.
Yeah.
Julie Anderson. I'm a social worker at the Food Resource Center. We had a grant that was funded through the city and the county. It was an ARPA grant that was providing mental health support for clients of the Food Resource Center. And actually really a majority of any community person who came to the Food Resource Center, if they needed help of any kind, we were there. That grant and the funding ran out December 31st. And as the only social worker left there at the Food Resource Center, we have really become in some ways a pseudo kind of receiving center in ourselves, just because of it being a place that's of safety, of comfort, I think a lot about like what you do. I mean, I'm connecting people to resources, whether that be SNAP, Medicaid, energy assistance. I also provide free therapy. I am continuing to see more and more crisis come into the Food Resource Center, and having an inability to respond or even have the hours in my day. I was late today actually with a client who was just released from our jail and is needing therapy services. They don't have any money, they don't have a car, they don't have any housing. They certainly don't have any funding to be able to find any long-term support for them or their family. And I'm just like, from my heart, I'm thanking you for taking this on, and it's really needed. And isn't it funny that we're having a chili feed tonight? And that also, there's a level of loss in that family too. So.
Thank you. Christina.
Christina Nelson, we have rental properties and we get to see some of the better side of things sometimes. And sometimes they don't turn out to be the good part either. When we have 3 right now that have been in programs and are in the like pre-release, and they contact us for rentals to get back out into the, like, you know, this, without getting back into things. And I've had a few of them end up calling me too for things, and along with rental assistance and stuff like that. So it's kind of nice to see the other part of it when, you know, they get out and they have help along the way.
Thank you. Patricia.
Yeah, I just want to say, underscore what you said, Clint. 25 years of watching this in Livingston, Montana, and watching really good programs come and go. And that relationship between the person who provides the service and the receiver goes when the grant goes, when the whole thing goes. So there's just this really intelligent continuity that this kind of program will provide, which is, and being next to Bozeman, as you know, sometimes it just ends up over in Bozeman, and we're not treated as a complete community, which you represent that community, So I was a statewide teacher trainer on suicide prevention in the state of Alaska, and I flew all over the villages. And the reality is that you have to have continuity, or it fizzles and then it rises and it fizzles and rises. So this is really smart. So thank you so much for considering this.
Is there anybody online? If you're on your phone, you can dial *6. Otherwise, you should be able to just unmute yourself.
Can you hear me?
Yes, go ahead. Name, please.
Hi, everyone. Violet Bolstridge. I am the Special Populations Section Supervisor for DPHHS. I oversee the crisis diversion grant funding and Heart Jail grant funding, as well as the development and implementation of various crisis Medicaid and non-Medicaid services. I've worked closely with Joe, well, my staff and I have, since he has been in that position, and I just want to emphasize the amazing work that he has done to bring all of your collective momentum consolidated into communicating and collaborating with the department. So I just want to first off thank Joe for all of the dedicated work and all of the other stakeholders there that I get the pleasure of working with more regularly. We at the department are extremely excited about different funding opportunities that we can put forth to help sustain crisis services and other preventative services that will be coming down the pipeline. And I just want to emphasize the importance of having a unified, collaborative, local approach to this work. Having our point of contact be Joe means the department does know that your coalition is putting a lot of meaningful thought into the work that you're doing and the solutions you're proposing. And we then have the tools to be sure to amend services and policies to fit what you guys bring to the table. So I want to thank you all for your time and dedication to this work and recognition of its importance. And I'm very encouraged by all the words that were shared today. So thank you so much.
Thank you. Anybody else?
I'll speak. My name is Michelle Frierson. I'm an LAC at Southwest. I don't know, many of you may know Daryl Brunson. He's a pastor at Expedition Church, and I know he really wants to get more and more involved in the community, and this is an issue that's heavy on his heart. But Is there, or to what extent can churches be involved in making this move forward? Whether that be time, energy, finances. Obviously, I can't speak on his behalf, but I think we would be very willing. Chad, Bryce, other pastors of these churches, I think would also.
Thank you.
When's our coalition meetings, Joe?
Second Tuesday of every month.
At
At 11
at
o'clock
11 o'clock.
in here.
Michelle? Trying to let her know.
Michelle, the Crisis Coalition meets every second Tuesday at 11 o'clock to 12:30 right in this room.
If, you know, Michelle, I can send an email out to you and you,
Awesome.
you can connect me with your community partners and we'll just update them on our progress.
And they're welcome to the meeting.
Yes.
Anybody else? Anybody online?
I gotta keep thinking about this, I'm just gonna say, not only are we like dealing with the crisis at hand right there, but in Park County, we have a massive amount of like this generational loss too. So we have uncles or family members who have also completed suicide or have struggles with substance use, crisis need. And I work with a lot of children too. So I think that the work that we're doing here now is also gonna funnel down the road to the children in the family, to our neighbors, to our siblings. It's not just this one individual that we're helping in need. It's really probably a gamut of 10 others that are attached to that person. We've also had strong, I think, difficulty filling positions in law enforcement and retaining our help. And this would be a great way to retain people. If you get burned out, if you're working a job that you don't feel that you have the tools for, you're gonna be seeking another position because it's too much for you. And so I think that this also, in some ways, is helping our law enforcement and our first responders stay here and be employed here in our community.
Thank you.
We do have one person on the phone and it just looks like you're unmuted, so I just want to make sure the last 4 digits of your number are 9527.
Last call.
We have 13 people online total, so if you'd like to make a comment, please do so.
Hearing none. Do we have a motion to adjourn?
So move.
We have a second.
Yeah, you can send me.
We are adjourned at 7:04.
Thank you.
Thank you, Carl.